We should remotely monitor our patients to understand about how they're using their device. Are they able to use the device every day? Or are they using it for a short period of time? Or are they not using it at all? Out of that population, I would want to target the patient initially that isn't using the device, make contact and find out why this is, and then hopefully be able to resolve the problem. Next, I would target patients that are trying to use the device but only able to use it for a short period of time. Is the reason for this the fact that the settings are uncomfortable and that these need to be adjusted? Or are they having issues with mask leak or dryness? Again, once the problem's identified, I would then aim to resolve this issue. Likewise, I'm also interested in patients that use the device well, and I would want to ensure that there aren't any problems around excess mask leak that perhaps they're not complaining about that could cause problems down the line. And finally, the patients that I want to know about are those patients that are using their ventilator more than what would be expected, as this could indicate a respiratory exacerbation and cause a change in their disease process. Or are they having a natural progression of their disease? And again, by contacting the patient, because I've got an alert, means that I can identify which patients are having problems and potentially resolve that. And that may include optimization of settings. And this was quite nicely shown in a study that occurred during the pandemic that looked at patients that were receiving remote monitoring via ventilator platforms, followed by telephone calls to those that weren't. And it was shown that patients with problems were identified earlier and that these problems could pretty much be resolved remotely, improving the patient's symptoms and resolving any problems with their ventilator. I believe that all patients benefit from telemonitoring. Patients have expressed to me that they feel reassured by the fact that we're looking at them and we're monitoring them and we can see how well they're doing. And that can also help to adopt adherence in this group of patients, in that they know that someone is looking out for them and that they're caring for them. I think as a clinician, we can't simply send patients home with devices and expect them to come back to clinic 3 months later and that nothing may have happened in that period because they haven't reported a problem. We need to have data in real time in order to solve solutions and improve adherence. I think we've learned an awful lot from our obstructive sleep apnea population that has shown that early intervention with remote monitoring improves adherence. And we know in long-term mechanically ventilated patients that an improvement in adherence leads to an increase in survival. If you were to ask me, is there a specific disease category or severity of patient that benefits from telemonitoring? It's difficult to say. However, Federico Trucco and co-workers looked at a group of children who were provided with telemonitoring compared to a group that weren't. And in their study, they showed that after receiving telemonitoring, there was a decreased hospitalizations for all of the telemonitored patients compared to the run-in period 6 months before. And that this, when it was compared to the control group, was also lower. They looked at their patient severity and that they showed that actually the more severe patients that were monitored were less likely to be hospitalised than the mild to moderate disease. And I think that this is really interesting because often we think that patients that are severely affected by ventilatory failure have all of the tools that they need and that telemonitoring in this group might not be as beneficial. So I really do think that all patients that are discharged with a ventilation device should be followed up with remote monitoring. And I'm hoping that this would then in turn help prevent admissions, but it may also help us identify problems in this patient group early. New innovations always come with barriers. When we were setting up the Telegraph study, a major concern was the increased potential and workload that the staff would experience as a result of monitoring all of these patients. In order to prevent that, you have to have protocols in place before you're starting so that everyone knows exactly what they're doing. Also, action plans are important. So once you've identified a problem, it's acted on appropriately and escalated if required. I think another key thing is that patients need to understand when they're going to be monitored. That yes, monitoring occurs all of the time, but the data that's received will be acted on at certain times. And therefore, if there is an emergency situation, they're not waiting for you to contact them. They will seek help outside of the times that they know that people are looking at the data. We also found that the software that we were required to use for the Telegraph study required a designated computer and specific logons, and this can be a problem. Hellman and co-workers quantitatively looked at 16 studies that involved remote monitoring. They found that facilitators to adoption of remote monitoring included robust Wi-Fi connection, devices that were easy to use and friendly. And for patients, they found that the incentive of not having to come to a hospital and have the increased travel time for their appointment was a key driver for them adopting this technology. Barriers included log-on issues, slow data extraction, and for both the healthcare professional and the patients, a lack of physical contact as a result of the monitoring process was perceived as a concern. For me, telemonitoring doesn't happen in isolation. It's a tool in our toolkit and is used with face-to-face contact and video consultations to improve patient care. And this is the way that I see it going forward.